especially when we're talking di twins now, generally speaking, the pregnancy is going to go without any hitch. The problem, of course, is that doctors are not trained in the skills necessary to possibly deliver those twins vaginally anymore. And so even twins that are both head down are often being led down the path towards cesarean section.
Hi, I'm Rachel, owner of the NaturalBirth site, certified birth doula, childbirth educator, and midwife's assistant.
And I'm Tiffany Muniz, certified birth doula, lactation counselor, and midwife assistant.
Here, you'll learn all about different aspects of pregnancy, birth, and postpartum.
Remember, none of this information should take the place of your care provider and is not medical advice.
Birth is not a medical emergency.
Thanks for listening.
Hey listeners, welcome to the Natural Birth Talk. Today we are here with Dr. Stuart Fischbein, which Tiffany and I are both so excited about. And today we're going to talk about twins. But before we jump into twins specifically, we're going to let Dr. Stu introduce himself.
That's my cue?
That's your cue.
Okay. Well, Rachel, Tiffany, thank you for having me on. I always like to speak to an audience that I may not have encountered before, because I think the message that you guys are sharing and that I'm involved with as well is so important. Who am I? Well, I'm a obstetrician. I'll give you my backstory as fast as I can. I don't want to spend a lot of time on it. Some people probably know me a little bit.
Sure.
I'm an obstetrician, but I'm a unique obstetrician because right now I do. Well, actually, I've stopped for taking a break from doing birthing. I was doing birthing for 40 years. I started in going to the University of Minnesota, which was my home state. I went to medical school there. I matched my residency in Southern California at Cedars-Sinai Medical Center in obstetrics and gynecology. The story of how I chose that is purely random. It's not. I didn't have an epiphany or a passion when I was growing up of catching babies or that sort of thing. It was just something that I sort of fell into. As a third-year medical student. You do rotations, and then you have to make a choice when you're really not prepared to make a choice of what you're going to do for the rest of your life, because you have to pick a specialty that you apply for residency programs. So those days you're young, naive, enthusiastic, but you don't really think about liability or hours on call or lifestyle or anything like that when you're young. You just think about what do I enjoy most, and obstetrics was just the epiphany for me. I guess that's not the word. It was just the peak thing that I enjoyed the most as a medical student, because it had longitudinal care. You could take care of people for a long time, and then you got surgery, and you got endocrinology, and you got internal medicine and family practice and psychology, and of course you got to catch babies. So it just had everything, and it seemed great. So I ended up going to Cedars-Sinai in Los Angeles, and I was very fortunate there because in those days, in the early 80s, we had an affiliation with LA County University of Southern California Women's Hospital, which was the busiest hospital in the country in the early 80s, doing about 22,000 births a year.
Wow.
Which is about 65 babies a day. 65 babies a day. Yeah. And so you're there for 3 or 4 months as a second and third year resident. So you're getting all kinds of training. And that's why I was lucky, because I trained in an era where breech and twin and forceps and things like that. The skills that make my profession unique were taught as just normal core skills, and weren't taught as emergencies or taught as something to be avoided. I came out of residency, however, thinking that I was, the smartest. I guess I'm mixing my metaphors, the brightest bulb in the lamp or whatever else. And I think I knew what I knew. And I was very confident that what I had learned in residency was the way to take care of women, because I was brainwashed in residency program to think that the medicalization of birth was something that was so necessary. And in those days, it was a different era. You didn't come out and get a job working for a large HMO. You came out and you hung your shingle and you hustled to try to build a practice. And so I covered emergency rooms, and I backed up other doctors, took their call and assisted them in surgery. And I worked at some free clinics, and I built my practice that way. And one of the things that happened to me, which was fortuitous also, was that I was approached by some midwives in the local area and asked to be somebody who would take their transports from home. And I said, sure. And I didn't say sure because I thought midwifery was a good idea. I didn't say sure because I thought home birth was a good idea. I'm sure that at those days, I probably thought it was probably stupid. I did it because I wanted to make money. But it was one of those fortuitous things in life, because when women would be transferred from the home in a non-emergent fashion, we'd have lots of time sitting around in the lounge with the midwife to hang out and just talk. And I began to learn about a different way of thinking about pregnancy. And slowly but surely, I evolved to the point where I thought that midwifery model of care made a lot more sense for 85-90% of women than the model that I was practicing. You know, I was that guy in the hazmat suit had you up in lithotomy position, prepping your vulva with betadine and putting on sterile sleeves over your legs, and, you know, catching your baby and then immediately clamping the cord and showing you this beautiful thing that you just created, and then walking it across the room and setting it down in the warmer. That's what we did. That's what I thought was normal. And fortunately, I was open enough to realize that that isn't normal, and that isn't healthy, and that isn't right for most pregnancies. And so I started a collaborative practice with some midwives, and we worked in a hospital setting for 15 years. And after 15 years, they had never accepted us in the community. They had always made life harder for us. But we had really good results. But after 15 years, they found a way to get rid of us. And it's a story, I won't go into that, but so the choice was to fight them legally or to leave the hospital setting. And I chose at that point wisely, because I had some great advisors, midwives, and clients who encouraged me to start doing home birthing. And believe it or not, after 25 years of working in the hospital, I'd still never been to a home birth.
Wow.
So my first few clients that I had that wanted to do home birth with me, their deliveries went beautifully, which was, again, a fortuitous event, because had they not, I don't know that all these things would have happened. And the rest is sort of history. I began to get braver, and I began to realize that, you know, breeches and twins and diabetics and hypertensives don't have to go to the hospital, and they don't have to be induced or have to have a C-section. And I published a few papers on that. I wrote a book back in 2010 called Fearless Pregnancy. And now, because I've slowed down after 40 years of being on call, I am doing mostly teaching. I travel around the country and sometimes overseas to teach breech and twin skills.
Love it.
And I have a consulting service through my website, and I have a podcast that I work with my colleague Bliss Young. It's called the Birthing Instincts Podcast. And I advocate for choices and for informed consent and for normalizing things that used to be normal, like breech and twin vaginal birthing. So, because what we're doing in the medical model is not working.
Right.
We've got lousy outcomes worldwide and compared to the rest of the world, and we probably are getting worse, and we're getting more medicalized. And most women who have a baby love their baby, but they don't love the experience that they had having their baby, both in the prenatal period and also in the labor and delivery period. They end up with 1 in 3 women having cesarean sections, which is absurd.
Crazy.
50 years ago, it was 1 in 20, and now it's 1 in 3. And we have no improvement in outcomes for mothers or babies. Actually, worse for mothers, probably worse for babies too, for many reasons, and maybe we'll get to those later today. So that's where I am right now. I'm in the last third of my life, and I'm going to try to continue to advocate for those things. And every now and then, when it suits me or it works out, I would love to attend a birth. I do miss it slightly. I don't miss being on call, but I miss being at the birth itself.
Makes sense. Awesome. I love how you were open-minded enough to step into that midwifery model, because as I'm sure most of our listeners know, and obviously we all know, that most of the time OBs don't take that knowledge from the midwives and like run with it. They just kind of look at them as crazy and look at it as just, that's not what we do and that's not safe. But you were able to keep that open mind and take a step back and learn from the midwives you were working with. And, you know, it just all, like you said, it was fortuitous. It just all kind of lined up in such an amazing way that now you had this big home birth practice, and your podcast is huge and people love it and people learn from it. And I don't know, just think it's always so amazing when those events just line up so perfectly. And then when people like you are able to keep that open mind, no matter what medical school drilled into your head.
Yeah, that's a very interesting point, because I'm very sort of dogmatic in some of the things that I say and do, and I'm very confident in what I know and what I don't know, and yet I'm also I'm a very logical being, and I can look at something and I can say that makes a lot of sense to me, or that's really stupid.
Yeah.
And I can see it right away. And when I was talking to the midwives and I learned about mammalian birth, and I learned about these things that never got touched on in medical school or residency. No nutrition counseling, no breastfeeding teaching, nothing like that. But truly about how mammals give birth. And when you just think the simplicity of what you would do if your dog was in labor, and how different you respond to them than you would if your wife was in labor, in the medical model. And why do we do that? And we do that because we're indoctrinated to believe that. And that sort of thing does not sit well with me. One of the things I always say was I respect authority, but I don't respect stupid authority.
Yeah, that sounds like me, Tiffany.
Smart people understand that.
Yeah.
They can differentiate between when someone tells you something that's really stupid versus something that makes sense, and everybody has to decide for themselves. And I thank my parents for giving me the background to have the open mind to be able to look at a situation, analyze it, and say, maybe I should have gone left when I went right. Right.
Yeah.
And it's okay to admit that you made a mistake. A confident person knows they don't know everything. It's the insecure person that is, very dogmatic and obtuse and insists that their way is the only way.
Yeah. You're so right about that. Yep.
Yeah.
We see it all the time.
Yeah. Every day.
Every day.
So
every day. And not just in our profession. I mean, just
True.
every day in the news, every day in your own personal life, you see people clinging to things that just don't make sense. And there's no way that you're going to change them. I mean, we could go off on a tangent about cognitive dissonance and mass formation, all that stuff, but that's probably not what your listeners want to hear.
Probably not. Although Tiffany and I could totally dive into that conversation.
Right.
So let's talk about twins, because I know you have so many skills. Breech and twins, I think, are what people specifically think of when they think of you. I have a good amount of stuff on the podcast about breech, but I don't have a whole lot about twins. So I'd really, really love to be able to talk about that today, just kind of your perspective or your thoughts or your experience, whatever you want to say. Okay.
Well, twins is one of those things that, again, in the medical model, from the moment you discover you have twins, you're categorized as high risk, and everything about that is wrong. I mean, you may end up being high risk, but to immediately label somebody makes them more anxious, more nervous, more likely to become high risk, more likely to develop problems, certainly to be bathing their baby in fear and anxiety for the entire 9 months, as opposed to joy and love and confidence. So why is that? Well, that's how the medical model looks at all pregnancies. They don't look at twins really any differently than they do at singletons. They always look at it as a problem waiting to happen. They just think that twins is more likely to have a problem waiting to happen. And indirectly, that is true. But it's not that it's more likely to have happen. It's what's the actual risk of something bad happening, and what's the risk of all the interventions of the medical model causing those things to happen, or things that wouldn't have happened otherwise to happen. All the surveillance and finding little things that don't really mean anything but make you worry, or telling you at 10 weeks that because you have this kind of twin that you're going to need to be induced at 36 weeks, or whatever. They plant all these seeds of worry, and then they just fester for the entire months. People should consider that twins have the potential for something to go wrong, but most of the time it doesn't. Just like life in general. Okay.
Right.
Just like driving to the grocery store. All right. They're not great analogies, but I think that people understand what I'm trying to say, is that we need to reframe how people look at pregnancy and get it away from being a medical problem and being in the midwifery model where it's looked at as a normal function of the body that occasionally goes awry, and that midwives in their model are accepting of uncertainty.
Yeah.
My colleagues in the medical model hate uncertainty. And they hate, what I like to say is they hate chaos.
Yeah.
And in their overzeal to correct for nature's chaos, they create all kinds of chaos and problems. But that's okay for them because it's their problems. And the problems they create, they feel comfortable with. But problems that come up that they don't feel comfortable with makes them very anxious. So they want to try to control issue. Everything.
Right. Yeah. Yep.
Right. And by the way, just as an aside, it happens that a control issue leads to more revenue generation. So
that's true.
That's something you have to think about.
C-sections and inductions cost a lot more than natural births.
Yeah.
Well, it just all the surveillance.
Yeah.
All the labs.
Yep.
All the ultrasounds, all that stuff that goes on, that creates more revenue. So again, the incentives in my profession are all backwards. That's another conversation for another podcast about how the corporatization and the medicalization of our health is an industry that whose people that run it, their ethics and their fiduciary duty are not the same as those of us that are actually working in it.
Right.
Their fiduciary duty is to make a profit for their company or their practice. And ours is to ethically be responsible to our individual client. Right. But the two don't mesh. They conflict. Anyway, back to twins. So twins are fairly common. There used to be about 1 in 80 pregnancies. Now it's about 1 in 32. Most of that has to do with IVF. Some of it may have to do with an older maternal population, women waiting till later to get pregnant. There's a slightly greater risk of twinning at that point. And so, but 1 in 32. So it's the same. It's about 3%, which is the same as breech twin delivery. It's far more common than having red hair. And we don't consider people with red hair to be abnormal, but we consider people with twins or breeches to be abnormal. And
that's a really good point. I have 2 redheads, just for the record, but that's a good comparison to think about.
Well, again, numbers can be altered to funnel you down a path that whoever's giving the numbers wants to take. And there's a big thing we'll probably get to relative risk versus actual risk shortly, but so about 1 in 32 pregnancies are twins. And about maybe 80% of twins are what are called die-die, which are 2 individual eggs that get fertilized. We're not going to go off on the real remote little other things. We'll stick to the basis. But we also call them fraternal twins or non-identical twins. And those kind of twins have less risk to them than what are called monodi twins, where the twins are identical in the same chorion but have separate amnions. Those twins have about a 15 to 17% chance of having some placental anomaly that can lead to a very serious problem. And then there's really the rare case of what's called mono twins, where the twins are in the same sac. And that has a very high morbidity and mortality rate as well. But that's, again, we're talking a very small percentage. So most twins, when you're diagnosed, are going to be die-die. And all that means is that you have 2 babies growing in there instead of 1. What's the increased risk of that? Well, there's a slight increased risk of preterm labor. There's a slight increased risk of one of the babies not growing well. There's a slight increased risk of things like preeclampsia. But if they don't happen, then the only risk is that you have 2 babies instead of 1. So you have 1 delivery followed by another baby. That's it. You have instead of having babies 2 years apart, you have babies 20 minutes apart. It's like but it's you're having a baby and then having another baby. But the medical model doesn't see it that way. The medical model is always looking for potential problems, and in their zeal to find them, they often will find things that aren't really problems, but they'll be something that they'll make into a problem.
That happens even with singletons.
It happens all the time.
Yeah, right.
It's one of the problems with the detailed ultrasound machines that we have now, and the zeal to that 20-week ultrasound to do all kinds of things like color flow Doppler and other things that find a little ditzel that doesn't really mean anything, and they tell you it doesn't mean anything. But then they tell you they want to see you back in 4 to 6 weeks to see that it still doesn't mean anything.
Right.
And the analogy that I use all the time is the movie Inception. And if you tell someone not to think about elephants,
They're going to think about elephants.
they're going to think about elephants. So what's the woman going to think about for 6 weeks? There's something wrong with her baby, even though there's nothing wrong with her baby.
Right.
Same thing with twins. If they tell you at 12 weeks, when they find out you have twins, that all these things can go wrong and that we really probably need to induce you, maybe they won't go wrong, but they might go wrong. Now, I understand the difference between giving informed consent and giving skewed informed consent. And you might want to, but it's how things are presented. And doctors, again, because they live in a fear-based world, they present things in that way. They don't even know that they're doing it. I was that person. And
I just had a run-in. It was actually with a midwife just a couple days ago who, Tiffany, I haven't even told you the story yet. I will after this.
No, I was going to say this is news to me.
I was in like 48 hours of births in a 56-hour time period. But one of them, the midwife, like the mom had slightly elevated blood pressure, like slightly elevated, okay? And had this minor like come and go headache, but it was going away with Tylenol, but it was like an allergy thing. But because she had a tiny headache and slightly elevated blood pressure, the midwife was freaking out. Tiffany, I'm sure you know which midwife I'm talking about, or have a guess.
I have a few guesses. Yeah.
The midwife was freaking out and was like throwing all of this fear language and talking about mom having a seizure if her blood pressure gets too high and how she shouldn't go home and blah, blah, blah. Anyway, it was crazy. And it was so much fear. It was so much fear. And luckily, this particular couple was able to get past the fear and they went home and they ended up having an amazing natural birth with zero issues at all. But this midwife wanted to put her on magnesium, like because she was scared.
Yeah. And
that's what happens, even more often with twins, but it can happen with any birth. It's crazy.
Yeah. It's I have empathy for my colleagues who are stuck in this box of the medical model. And if they don't have the energy, the curiosity, whatever, they're beaten down to the point where they're not even trying to look over the walls of the box to see what's on the outside. And they live in that world, and it's a world of adrenal fatigue. It's the world of stress.
Yeah.
It's a world of, if you're constantly being anxious or fearful about what you're doing in your job every day, that's not a great way to live.
No.
Part of me says that they should fix it. They should climb out of there themselves, but I understand the pressures on doctors and nurses to just conform.
Yeah.
That gets us back to the whole mass formation and stage 1 thinking and all that other
Yep.
well, it all comes back to that. But anyway, with twins, especially when we're talking die twins now, generally speaking, the pregnancy is going to go without any hitch. The problem, of course, is that doctors are not trained in the skills necessary to possibly deliver those twins vaginally anymore. And so even twins that are both head down are often being led down the path towards cesarean section. But let's talk about that for a second. About a little over 50% of twins will have at least one of the twins being breech. About 40-some% of the twins will be head down, and 50-some% will be at least one twin breech. Could be breech vertex breech, or breech. And then there's a 2 or 3% that where the babies will be sideways or some other weird thing where the cord is presenting or something like that. So taking those out of the picture, we know that more than half of twins are going to have at least a breech baby in it.
Right.
We know that most OBs will not do a breech delivery even with a twin anymore. The sad thing for me is that doctors who find out that you're having twins at 12 weeks who don't do breech don't tell you that I'm not an expert in twins. You should go someplace else. And that's what, if I would tell one thing to any of your listeners who are having twins, find out from very early on, is your doctor an expert in taking care of twins? And I don't mean anybody's like a twin expert. I just mean that they have the skills to assist a baby that's breech.
Yeah.
Because more than half the time it's going to be that way. And if they're not telling you that, and then you get to term and you have a vertex breech set of twins or a breech vertex set of twins, they're going to tell you, well, that's not safe. Your babies could get stuck, or something could happen, or the heads could get locked, or breech is dangerous. And they skew their counseling to force you to have a C-section. And that's wrong. Yeah. That is incorrect. That's not good medicine. That's not what should be done. These people should be referred out early on.
Agree.
And then when you go in with twins, you usually go into labor. They want to, the American College of OBGYN is also very fear-based. Their consensus opinions are often just that. Their consensus opinion statements are just opinions. And what kind of opinion do you expect from, 5 guys who are all maternal fetal medicine specialists who all trained in the same way? I'm not saying there's 5 guys. I made up that number,
right.
but I don't know how many guys, but they're all groupthink.
Right.
And so they all think alike, and they all think in terms of recommendations. And even much to their credit, ACOG admitted that 2/3 of their recommendations are based on opinion alone and not based on any science whatsoever. So
red flag.
Lots of red flags, and you can't trust science at all right now. We're all learning that it's all influenced by money and big pharma, and they publish things that they want published, and things that are maybe contrary to the narrative will never get published. They'll never see the light of day. It's very difficult right now. It's been difficult for a long time. It's just that we're waking up right now, and we're understanding that. So there's a growing movement of people that are pulling away from the medicalized birth model, and I can't say that this happened soon enough.
Right.
Yeah.
The medical system is great. I just had eye surgery. It probably saved my vision. So I'm not condemning medical system completely, but I'm condemning its overuse, and certainly it's overused in twin birthing.
Right.
And then they'll want to induce you with twins. The ACOG will recommend that with die twins by 37 to 38 weeks, you should be delivered.
Which is crazy, because it's like these are already babies who are probably smaller than a singleton, and then we want them to be born even sooner.
Yeah,
just in case.
Well, let's see. Their concern is the risk of stillbirth. Okay, and that should concern us all. But the question is, what's the actual risk of stillbirth?
Right.
And this is where it gets really clear to me. If you just dig deep in it, if you take a woman with die twins, or even mono-die twins who make it to term without any evidence of that placental problem that I was talking about before, called twin-to-twin transfusion syndrome. But if they get to term, and they don't have preeclampsia, they don't have growth restriction, and they don't have diabetes. All right. So in other words, a normal, healthy mom who just has twins. The chance of a baby having a stillbirth at around 36 to 37 weeks is about 7 per 10,000.
That's pretty low.
The chance at 38 and 39 weeks is about 14 per 10,000.
So it doubles.
It doubles.
And that's what scares people. It's the same with after 42 weeks. It's like it doubles. Oh my gosh, it's so scary. But then you look at the absolute risk and you're like, oh wait.
And the absolute risk is the difference is between 99.93% chance of it not happening. And a 99.86% chance of it not happening.
Yeah. So it barely changes in reality when you look at
in reality, it barely
risk.
changes, but you could say the risk doubles.
Right. Yeah. Exactly.
And if you wait till 40 weeks, it actually goes up 7-fold.
But is
7-fold
really
is still a 99.54% chance of it not happening.
Yep.
Yeah.
So
go ahead. I'm sorry, Tiff.
Sorry. My best friend, who I've been best friends with since 7th grade, she had die twins, and she really didn't want to get induced. So baby A was head down, baby B was breech. The hospital where she was at, they agreed to attempt a vaginal birth because baby A was head down. Yeah, right. Exactly. They told her, she had, of course, a couple late-term ultrasounds. They told her that they were worried because the babies were so big, both measuring about 8 pounds. They were worried. So they had been asking her, please, let's set an induction date for 37 weeks. She said no. 38 weeks. She said no. Finally, at 39 weeks, she caved. So she set her induction date up for like 39 and 2. It was a fairly quick induction. And so baby A was head down. They did this whole thing where they like rushed her to the OR as soon as she was 10 centimeters. And she ended up having a vaginal birth. But baby B, they didn't even give baby B time to like be born. So baby A was born, and she said that there was a resident there and that he, like without her consent or anything, just stuck his hand up there and grabbed baby B's feet and, pulled baby B out. She said there was like no emergency. And then all of that And babies were 7'2" and 6'2".
So big.
Right.
It's crazy
Yeah,
how they went
look
from
at-
8-something pounds to suddenly being 7 and 6 pounds.
Yeah, see,
Crazy how that works.
Doctors like that, they have what I call the Goldilocks theory. Okay.
Okay.
The porridge is too hot or the porridge is too cold. The porridge
Yep.
is never just right. Okay.
Right.
Uh-huh.
Yep.
Right. The bed is too soft. The bed is too hard. The bed is never
Yeah.
just right. So the babies are too big. The babies are too small. Mama's too old. Mama's
Yep.
too young.
Mhm.
Yep.
Your hips are too small. Your husband's too tall. It
Too
doesn't
far
really-
into pregnancy.
And she had an amazing pregnancy, no diabetes, no high blood, not one single high blood pressure. Labs were always perfect. Like everything was perfect. Like this could have all been avoided. You know, she was kind of traumatized, obviously, by that experience. How could you not be?
That's
Yeah.
the way twins are managed in the hospital, though.
Yeah. Yeah.
Is the first if they even allow you to do a vaginal delivery, the
Yeah.
first twin will come out and they'll immediately go up and AROM the second twin, and then
Yeah.
they'll have the mom push, even if she's numb or if she isn't feeling pushing. If the head's down, if it's breached, they'll often do a breech extraction.
Mhm.
I admire the fact that they even did a breech extraction. They shouldn't do it without telling her, and they should have
Mhm.
this should all been discussed during the
Mhm.
prenatal period of how we manage these things.
Mhm.
But I will tell you the reason it's done that way is, one, the long habit of not thinking something wrong gives it the superficial appearance of being right.
Mhm.
And two is expediency. You've got 10 people sitting around in the
Mhm.
operating room.
Yep.
Two teams of pediatric people. You've got an anesthesiologist. You've got a bunch of nurses in there. The hospital can't afford to have those people sitting around for an hour and a half between
Right.
babies. So it's all done for the convenience of the hospital.
Mhm.
Mhm.
Another thing I talk about too, from the moment you drive to the hospital till the moment you put your baby in the car seat to drive home, pretty much everything that's done to you is antithetical to mammalian birth. And also none of it is for the benefit of the mother.
Right.
From the moment you walk in, they're making you pee in a cup and changing into a hospital gown. Why?
Because it's policy or it's routine.
Yeah, right.
Because
they have to.
that's how they do it.
Well, they
how
can
they do
charge
it.
for the urine, and then the hospital gown is a sign of disempowerment.
Yep.
Then they put you on the belts on you. They have to put an IV in you. Why? Why do you need an IV?
Right.
Why do you need blood drawn? Why do you need blood drawn? How do we have babies at home without drawing their blood? Oh my God.
Yeah.
Right.
How does that happen?
Yeah.
All right. Well, they say, well, we have to have a clot in the blood bank in case you have hemorrhaging. Why? You handle people who come in from a car accident just fine.
Right.
That's true.
If you have to give O negative blood, you give O negative blood. But no, because there's hospital charges for all these things.
Mhm.
Yeah.
Why do you need to know my hemoglobin? My hemoglobin's been fine my entire pregnancy. We have to know. Well, we have to know your. Okay, I could understand if the woman may want an epidural, the anesthesiologist may want to know the platelet count, because the platelet count's below 70 or 50,000, then maybe. But what's the odds of that happening? But these are routine things that are done on every single woman.
Mhm.
They have protocols for how often they have to take their blood pressure. How often at a home birth, when you take a blood pressure when you first get to their house and it's 100/68, does that woman suddenly become a hypertensive crisis?
Right.
Never.
No.
Okay. And if they're hypotensive, they're going to become symptomatic. You're going to be able to tell it. Then you'll take their blood pressure. But to interrupt the labor every 30 minutes or every 60 minutes or whatever it is, to have that blood pressure cuff blow up is just, it's robotic. It's not, it makes no medical sense to do it on everyone.
Right.
But the hospital, despite these highly trained nurses and these highly trained doctors, the hospital doesn't trust them to use their judgment.
Right.
I don't know, I know this is hyperbole, but I don't know why anyone would want to go to medical school right now. Because anybody who likes to be shepherd rather than sheep doesn't want to go through all that training, all those years, losing your entire 20s decade, owing $150,000 to $200,000 when you get out, to come out and then be told by some computer algorithm or business major how you're supposed to practice your trade. Yeah. Why would you want to do that?
Right.
And so what's happening is most people who are shepherds by nature are not going into medicine anymore. And you're ending up with sheep, which is perfect for the people that are running the system.
Yeah. That's
They're driving
so
private
true.
practice.
Yeah.
They're driving private practice out of business
Yeah.
purposely by passing legislation and laws that
Mhm.
make it that are lobbied for by big hospitals and big industry to make it more difficult for the private practitioner to survive
Mhm.
financially.
Yeah.
You know, it could be everybody's got to do electronic medical records, or everybody's got to take all these courses, or you have to do all these things that if you have a big office where you have an HR department and other things, that can be taken care of. But if you're a small practitioner,
Mhm.
you don't have the time or the finances to be competing with these things. So you end up selling your practice and going in and working for a big corp.
Mhm.
And
then you're
so,
told what to do and how to do
Right.
it. And
Yeah.
you don't have that
And-
autonomy as a practitioner anymore.
because why? Because the medical system does not like chaos. I said
Mhm.
that earlier.
Uh-huh.
And they like to control things, and you can't control individual cats.
Right.
You can
Mm.
control the herd of cattle, but not
Mhm.
cats.
Yeah.
Right. And so the
Yep.
private practitioner was always like a cat. Like I got a cat sleeping over there, and I can't ever get her to do whatever I want.
No, never.
Right.
They don't listen.
Right. Right. But if you have a herd of sheep, you can have a dog. It can tell them exactly where to go, and they'll
Uh-huh.
just do exactly what they're told.
For the
Right.
record, that's why I'm a cat person and not a dog person. Because dogs just give away their love to everybody, and that's crap love. Cats, you have to earn their love because they're not
Okay.
going to listen to you if they don't love you.
That's
That's my
right.
little cat versus dog tangent.
Right. Okay. So back to twins. How should twins be managed? If they're uncomplicated,
Mhm.
they don't have preterm labor, premature rupture of membranes, preeclampsia, growth restriction, that sort of thing. True growth restriction.
Mhm.
I mean, twins grow at a
That's tricky
smaller.
too, right?
Yeah.
Right.
Well, often doctors will use the nomogram for singletons
Mm-hmm.
on their ultrasound reports, and they'll show that the baby's less than the 5th percentile, but the baby's always been in less than the 10th percentile, and so that baby's growing. It's just
Mhm.
small, and they'll call it growth restricted, even
Yep.
though it's growing
Yeah.
normally.
I've had that
And-
happen with a singleton before with a client. I mean,
Yeah.
instead of looking at their growth curve, they're just looking at a percentage.
Mhm.
And by the way, the fact is that when you again, it's a failure to think logically.
Mm-hmm.
A growth curve means that some people have to be at the 97th percentile, and some
Uh-huh.
people have to be at the 3rd percentile,
Right.
and that's normal.
Mm-hmm.
Yeah.
Okay. But now we label everyone under the 10th percentile as being abnormal when 10% of people are going to
Are
be under the
supposed to
10th
be that
percentile.
way. Right.
That's how math works.
That's just how they are.
Right.
Okay. But everything has to fall on an algorithm in the medical model, and every woman has to have her blood drawn, and every woman has to be monitored, and every woman, has to have ice chips. If you're lucky, you get a popsicle. The idea
Right.
that you're going to starve somebody for 20 hours doing some
And
of the
then
most
wonder
intense
why
work
their blood
possible.
pressure dropped, or wonder why they hemorrhaged, or wonder why XYZ happened. 'Cause
Their
you
blood sugar
starved
bottoms
them.
out, or the baby
Yeah.
doesn't tolerate labor that well.
Yeah.
I mean,
It's barbaric.
so how should twins be managed? Well, again, with di twins or mono-di twins that make it to term without any evidence of that problem we talked about. We've got Rixa Fries and I, who runs Breach Without Borders,
Yeah.
and also was my co-author on a breach paper we did in 2018. We have a paper coming out hopefully next month, maybe by August, that will be on twins.
Awesome.
And our average twin mom went to 39 weeks in 0 days.
Mhm.
So, and we had some that went at 35 and a half weeks. So if we have some that go at 35 and a half, 36, 37 weeks, we also had some that went to 40, 41, and 42 weeks.
Uh-huh.
Yeah.
All right. Our outcomes were great.
That's awesome.
And yes, there's even me, who's still got that ingrained sense of obstetrician buried in me someplace,
Mhm.
I would get a little uncomfortable. I would never say anything, because if the testing of the babies was fine, or if the mother was reporting that they're fine, or the mother didn't want testing, or the mother decided that she just wanted to wait, that was her informed decision. We
Mhm.
honored that.
Good
But the
for you.
outcomes were really quite good, just waiting until labor ensued, which has got to be better for mom and baby overall.
Right.
Babies
Mhm.
picking their due date, babies being exposed to mom's hormones during labor and the microbiome and all that have to be better than getting artificial Pitocin or just a
Yeah.
scheduled C-section, which alters the epigenetics, alters the microbiome.
Mhm.
Look, we have problems with our children growing up right now in the United States. We have a chronic
Mhm.
immune problem in over 50% of our children, apparently. Used to be single digits 20 years ago. Now that's a combination maybe of vaccines. It could be a combination of toxins in our diet and GMO and other things that are going on, certainly, and how we give birth and how we're colonized at the beginning and what hormones we're exposed to with our mom and our skin to skin and our bonding.
Yep.
It matters.
Sets us all up for that.
Yeah.
And, we may see babies born by cesarean section or with traumatic births or an altered microbiome because mom got tons of antibiotics in labor. And that baby may be okay, but it may have some autonomic nervous system dysfunction or something that sets it up to be more vulnerable to these other toxins down the road. Because why is it that some babies, are fine, they get the whole vaccine schedule and do fine, and other babies, get one vaccine or two vaccines and they change their behavior. They develop, whether you believe it or not, you can't deny that there are parental story after parental story about my baby was fine until 2-year-old series of shots, and then now the baby doesn't make eye contact or speak anymore. Why does that baby? Would it be really interesting to look back and see that baby's birth history and that mom's antibiotic history and other things too? I don't know that you can ever do that because there's so many factors involved.
Right.
I was talking to somebody earlier today about the fact that it would be really interesting to compare babies born at home versus babies born in a hospital and see. The problem is that babies born at home, their parents are less likely to give them toxins.
Right.
They're going to feed them better. They're going to breastfeed for longer periods of time. They're going to probably not vaccinate their kids. So you can't
pin it down to just the home birth because there's all of these other factors.
Just the way we give birth, but again, there's something about nature's design that in the midwifery model, and they taught me to value that the medical model. There's a famous quote by two guys were supposedly giving a debate about the benefits or downsides of inducing women at 39 weeks. This was 2 years before the ARRIVE trial came out. This was an ACOG meeting, and I watched it online. And what's really interesting is that turns out that both guys actually were supportive of 39 weeks. It was in my opinion, it was a fake debate. Debates usually are but one of the two guys, I think his name was Dr. Norwood, said something like, nature is a very bad obstetrician.
And see, that's what's ingrained into you guys is that nature does it bad. But then when you look at how, the countries that heavily use midwifery care, those are the countries with the better mom and baby outcomes.
I would commend nature. For being a bad obstetrician.
That's true.
Obstetricians are bad arbiters of nature's design.
That's true. So nature should be bad at.
So he didn't. I don't think he understood what he was saying was really true, but for the wrong reason.
That's true.
Right. But I remember that. I'll remember that. I actually wrote about it once, and I wrote it in one of my blogs somewhere in my blog page on my website. So anyway, so you and then people say, well, okay, so we're waiting for spontaneous labor. Then what happens? Okay, well then you labor. If you're in the hospital, you advocate for what you want, which is be left
you get it
alone as much as possible. Try to avoid. They're going to want you to have an epidural in the hospital, even if they don't activate it. They're going to tell you, well, just in case. Well, just in case is bullshit. All right. They can manage you without an epidural. They just want to be able to potentially reach up inside you without permission and grab your baby and pull it out. And I will tell you that we do that at home without an epidural. We don't do it without permission though, but we do. Women are amazing, and they're able to, if it's for the benefit of their baby and they trust their practitioner, they're going to be able to allow you to do that. So the epidural is, again, it's the long habit of doing something one way and not thinking it wrong. But there's no reason to have an epidural prophylactically put in place. If you want an epidural for labor because you want that, that's fine.
Right.
All right. But you don't have it.
But to have a needle stuck in your spine and risk all the potential side effects of that, just in case.
Well, yeah. And again, I will give the anesthesiologist credit. They're really good at it. And so the side effects are really small. And then, that I give them credit on that. But the question is, it's not the anesthesiologist that wants it in there. It's the OB that wants it in there.
Right.
And there's no reason to do that. There's no reason to starve yourself. So if you have a hospital that says you can have ice chips or a popsicle, then you have your husband sneak in
Right.
food.
Yeah.
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 Yeah. Or hire a doula like Tiffany or I who will just feed you anyway.
Right.
Correct. And then if they tell you you have to be monitored all the time, then you just tell them that, you know what, I think I have to go to the bathroom.
And you just stay in there.
And then you just stay in the
and you just
bathroom.
labor in the bathroom. I know that it's terrible to sit there and labor in the bathroom, but that's what you have to do.
Yeah.
So you find ways around the rules because the
Mhm.
rules are generally stupid.
Yep.
Remember what we talked about before? We respect authority. We just don't respect stupid authority.
Right.
Most of the things the hospitals do are done for the benefit of the hospital and not for the benefit of the mother.
Yeah.
Right.
And especially in the case of twins.
So then you're in labor and they're going to want to take you back to the OR because that's a policy that makes no sense whatsoever. Again, it's, well, just in case. Yeah, but you're disrupting the labor process. Sarah Buckley likes to say labor should be safe, quiet, and unobserved.
Yep.
And every time you walk into a room and ask the woman a question, or even just disturb, make sounds, you're actually, that's an intervention.
Right.
Bliss likes to say that.
Yeah.
So it is an intervention. But when you specifically get a woman and move her from one bed to another down the hall and put her in another room, that's really disruptive to the process. Why are they doing that? Well, just in case you need a crash C-section. Well, what happens to the singleton who needs a crash C-section? They run them down the hall.
Right.
Yeah.
So why can't you do that with a twin?
Right.
Exactly.
Yep.
So then the first baby will come out, and it's perfectly fine to have delayed cord clamping for as long as possible.
Yeah. You don't even have to cut the cord.
No, you don't
between
have to.
births
Although
if you don't want it.
sometimes, if you're getting serious with the second twin and the first twin's cord is short,
Yeah,
and stuff,
it's
you
hard.
might have to move that baby out of the way.
Yeah.
So you cut the cord and you hand the baby to dad, and the dad can do skin to skin, and then mom gets serious with baby B. Now, the average interval for between one twin and the second twin in our study, if I remember correctly, was about 38 minutes, but that might be wrong.
Okay.
We had
but a significant amount of time.
Anywhere from 2 minutes to 4 hours and 16 minutes.
Yeah.
Was the difference in time. I just found that after about 30 to 45 minutes, we started to see an increased rate of postpartum hemorrhage.
Okay.
Our numbers don't reach statistical significance. And also the literature does report that the longer the twin to twin interval goes, the more likely baby B is to have a lower pH. And a lower pH means potentially lower APGAR scores, more need for respiratory assistance, that sort of
Interesting.
thing.
Yeah.
So in the hospital, you probably rarely have 5 minutes between twin A and twin B with a vaginal birth. In the home setting, like I said, our average was, I think, in the high 30s to 40 minutes. But I really like to think that I would, if I was recommending somebody starting new in practice who's going to be doing twins, I'd say after 30 to 45 minutes, if nothing's happening, then have that discussion, obviously, long before during your prenatal care, that at that point may be rupturing membranes and trying to, get, obviously, before you do that, getting baby A to latch, to help bring down the oxytocin and doing that. But if that's not working, to get moving things along, simply because there may be more risk afterwards. Now, can I say how high the risk is? No, I can just say that I've observed a higher rate of postpartum hemorrhage. None of them requiring transfusion, however, but obviously a woman that's anemic is going to have slower recovery. They're going to be, maybe milk production will be a little bit less. So we want to try to avoid those sorts of blood loss things.
Yeah.
But some women will refuse, and that's fine. But that's the kind of informed consent that we give them.
Yeah.
And then the second twin comes out. Now, occasionally, very rarely, once in my 40 years, have I seen twin A's placenta come out before baby B.
Okay.
Almost always, people ask the question, well, what about the placentas? Well, they almost always come out after both twins are out. Because the way the placentas are usually detached is where the uterus contracts, and it causes the shearing of the placenta off of the uterine wall.
Right.
And after the first twin comes out, uterus doesn't really contract that much because you still have a 5 or 6 or 7 or 8 pound baby inside. And so it's not going to contract that much. So most of the time the placentas will come out after. The medical model will want to actively manage your third stage, which means they'll want to give Pitocin immediately after the second baby's out. We discussed that. We generally don't do that. We're very good at managing, paying attention to the fundus to keep it firm. And we have those medicines to strengthen the contractions of the uterus available. Home birth people carry Pitocin, usually misoprostol, often TXA.
Yep.
Oh, that's misoprostol.
Well, misoprostol, yeah. And then some people carry Methergin. Methergin requires refrigeration, however, and it's really hard to deal that. And then the Methergin pills got incredibly expensive, so that most people don't carry Methergin anymore. But we're prepared for that sort of thing. We bring IV fluids and stuff along with us. We don't start an IV routinely. Some women on rare occasions will have a history of postpartum hemorrhages in the past, and they may want one.
Yeah.
So we discuss these things, but everything in our model is the informed consent model, and ultimately the final decision belongs to the woman, not the institution or the physician who is projecting on them skewed information to funnel them down the path to take something that they may or may not want.
Right. And so like sometimes there's some care providers who are really great with singletons or do okay with singletons and are all about the informed consent. But the second, there's something skewed that's not textbook, in this case, twins, it's like that informed consent goes out the window just because you have twins. And it's crazy. And then the other thing, is what I'm hearing from all of this, and obviously with anything, is you need to be educated. Like, it's not just, going to an OB that you trust. Like, how do you know if you should trust that OB or not? Like, those are questions you have to ask, or even midwife, how do you know? But you have to be educated on a lot of these things. Cause like Dr. Sue's saying is, they just kind of tell you like it is, or they may give you skewed information. And if you don't know the difference, then you're just like, okay, yeah, that sounds like a good idea.
Yeah. Sadly, this is not a blanket statement, but it's mostly true, is that you can't trust your obstetrician anymore.
Yeah. Very rarely. We have like 2 or 3 in our area that are really great. And the rest are just like,
right.
And we live in a metropolitan area. Yeah. I mean, there are tons to choose from.
No, you can't. They only know what either they know or they, I can't believe the worst thing is that they know they're doing something wrong and they're doing it anyway. So I have to believe that they just think they're doing the right thing.
Right. Yeah. Right.
But they don't look at that. They don't look at their outcomes. They don't look at patient satisfaction. They don't look at that and say, listen, how did we end up with 1 in 3 women having a cesarean section and think we're doing the right thing?
They don't question it.
No.
So I did have one question about twins that maybe you can give some insight on. This comes from the only other episode we've done on twins, which is from a mom who was labeled as gestational diabetes within twins. But she was talking about how since then she's done some research to show, so with having twins, she was still given the same numbers to look at as whether you're labeled gestationally diabetic or not, as you would for a singleton. But she's done some research, and not a ton, but finding that those numbers should probably be a little bit higher if you're growing 2 babies versus 1. Do you have any insight?
I don't know that, but I will tell you bluntly, blanketly, I don't like hard numbers anyway.
Me neither. They're kind of arbitrary.
You're telling me that someone who drinks, first of all, drinking this stupid 200 calorie, 50 gram drink is not how people eat. And that's not, so some people are going to respond badly to that. But to tell me that somebody has a value of 139 and they're fine, but if they're 140, they're not fine.
Exactly.
Right.
Okay. So I don't like the numbers as it is. I think that gestational diabetes, once again, the parameters are set to catch everyone with gestational diabetes. In the process, they get a lot of false positives that create a lot of more anxiety for women because now they're labeled with something that really isn't an issue for them.
And then they want to spiral interventions from there.
You can see women fail the 1 hour glucose test. And then they do home finger sticks and their finger sticks are perfect for weeks.
Yeah.
They're still on the chart labeled as gestational diabetic.
Yep.
And therefore then they get all the extra monitoring and the extra anxiety and the potential inductions because they're and there's really nothing wrong with them.
Right.
And my colleagues they're spinning that hamster wheel and they can't get off. They can't think independently. They can't individualize their care. They can't understand that this woman has given birth to 3 9.5 pound babies before. This baby's 9 pounds. It's not macrosomic.
Right.
It's normal for her.
Normal for her. Yep.
Yeah.
I have somebody right now I spoke to yesterday who has twins at 34 or 35 weeks. They're about almost 4 pounds each, which is less than the third percentile on the Hadlock scale for singletons. But they're both growing okay. They're very concordant. And these are her first babies, but she was a 5.5 pound baby. Her two brothers were 5.5 pound babies at term. Her husband was a 5.5 pound baby at term. So they grow 5.5 pound babies. These twins, if they let them sit in there for another 4 weeks, will be 5.5 pounds or more. But they're telling her she needs to be induced now, which then guarantees the babies will end up in the NICU for 3 weeks.
Right.
And they're going to be even smaller than they would have been. Their struggles are going to be harder. It's just such a cycle.
There's just no critical
way of thinking. Yeah. And it's just,
they're doing all this testing. Guys, they're doing all this testing on the babies, the Doppler color and the biophysical profiles. Those are all perfect. And they're still telling you the same thing. So my question to her was, if they're doing all this testing and they're not trusting the testing, why are they doing the testing?
Right.
Well, and they say, well, the testing doesn't pick up everything. Well, nothing picks up.
Which is it? Which is it?
Right.
Yeah.
It's crazy. It's crazy. I'm so interested in learning more about gestational diabetes with twins. So if anybody's out there and you know some information about that, please send me an email. Because
I think you have more placental mass, so you're more likely to fail the test because you're If diabetes is related to human placental lactogen secretion and placental mass, then you're more likely to fail your 1 hour glucose test.
Yeah. Well, and you need sugars for 2 babies, not just 1 baby.
Yeah, but I think your body should regulate the sugar. Right. But it really should be screening people based on how they eat.
Yes.
And what we do in the midwifery model almost always is if we're going to do screening at all and we give them informed consent, some people refuse.
Right.
But if they do it, we ask them to do a 1 hour after eating a normal breakfast or a normal lunch, because I care more what Rachel eats and how she responds to her normal meal than I care how she responds to a bottle of 50 grams of sugar.
Right.
Which I would never consume in one sitting, ever.
Right.
So that's really in a nutshell, twins, and that's how we look at them. And again, when you see normal all the time, you're very quick to recognize abnormal.
Yeah.
And when and surveillance of twins, with monodi twins, they do need regular ultrasounds early on, from about 16 weeks till like 28 weeks. Every 2 weeks makes perfect sense, because this TTTS thing can appear at any time. It can even appear after 28 weeks, but I have it on pretty good authority that if you don't see any evidence by 28 weeks, the likelihood is much smaller in the third trimester. So you could space it out. But with di twins, scanning them every 3 to 4 weeks is probably not necessary.
Yeah.
For most twins, especially if the first couple scans, the 16-week scan, the 20-week scan are normal, you could space that out. Again, if you like seeing your babies, that's perfectly fine. But you have to understand that by doing scans that are not necessary, they're often going to find things that aren't really meaningful, but they're going to make you worry.
Yep.
Because
all the time.
Because the doctor will worry, and they'll project their anxiety onto you.
Yep.
And that's how the system propagates itself.
Yeah.
But that's really essentially it with twins. They're amazing. Women can do great with them.
Yeah.
If a problem develops, then it needs to be dealt with, and the hospital can be very valuable. If you have premature rupture of membranes, or you have TTTS, I mean, they have amazing surgery they can do. They were saving lives. In our paper, we had 4 moms that developed TTTS in the second trimester. All 4 of them had the surgery, and all 4 of them had their babies make it to viability, which was something that 30 years ago would not have happened.
Yeah. So there's benefit. There's benefit in the right medicine, in the right medical care. And you really have to just know how to distinguish what's actually necessary and what's just a bunch of people being nervous or wanting to be in control.
And it starts with finding a good practitioner and a good team.
Yeah.
And it's very hard to do that. It's really hard these days to know
it is
what you're getting in the obstetric model. But for the most part, ask your doctors. As I said early on, if your doctor's not comfortable with any baby being breached, then that doctor should not be taking care of you with twins.
Yeah,
period.
right.
Well, and I always say too, if you want to know, get some insight on the doctors or the care providers in your area, reach out to your local doulas. Because a lot of times the doulas have a lot of information that they can give you. And even from doula to doula, there's going to be different opinions on things. But, doulamatch.net is a really great place to go to find a local doula that you can ask and be like, hey, this is my situation. Who do you recommend? That can be a good first step.
Another option for that, and when I tell people when they move to a new town, is sometimes you can call the labor and delivery and ask to speak to one of the nurses and ask the nurses, if you were pregnant, who would you go to?
Yeah.
Secondly, they know who the doctors are that are good. Most nurses will tell you, you don't want to go to him. He always gets 4th degree tears. Or you don't want to go to him because his section rate is 45%, that sort of thing. So that's another thing that you can do. But you need to start with that. It's too bad that it's such a challenge.
Yeah.
To find somebody who's really qualified to take care of you with your twins.
Well, and so often it ends up being the home birth provider, which a lot of people aren't comfortable with or can't even afford, which is unfortunate.
Or it's illegal in your state.
Or it's illegal in your state, which sometimes there's still someone you can find.
But it might be something worth traveling for if because like anything else, you have to put value on it and how you give birth. And if you want to, say your first pregnancy is with twins and you want a 3rd or 4th baby, you want to avoid that C-section if you can. And so you need to find somebody to do that.
Yeah, because the long-term risks, we're looking at long-term risks too, not just the here and now.
Right. Any risk that they may averse by doing a C-section on you for this baby will just passes the risk downstream to subsequent babies.
Yep.
So, but I want to reassure people that if you have a confident twin practitioner, twins are just, it's a harder pregnancy. You're bigger and you're more uncomfortable. And then you've got baby sucking on both boobs at the same time. And you got a lot more, it's a lot of work. So prepare yourself and your social situation and your support team. Once you find out twins, you got to plan for not only the antepartum period, but the postpartum period as well.
Right.
Yeah. That is a really good point. We don't have time to talk about that, but that is a good point too. You really got to
No, and that's where the midwifery model and having postpartum doulas and people like that makes a lot of sense. The midwifery model does take care of you postpartum. The medical model, even with twins, will generally see you in 6 weeks. Right.
Yep. Before we finish up, I just really quickly want to tell my one little twin story that I had early on in my doula career. It was a mom. It was her 4th and 5th babies, I believe. And she found out she was pregnant with twins. It was a surprise pregnancy and it was twins. And she had unassisted births previously because she had done this and she was familiar with everything. She had fast labors. So she ended up having a midwife for this particular pregnancy, and she was having a home birth again. And she was in the pool and I was there and she started pushing and I saw it and I was like, oh, that's a foot.
Yeah.
And she had breech babies, breech twins at home in her birthing pool without the midwife sat in the corner and I just stood around the pool and observed, and that was it. And she caught her own babies and she did everything all by herself. And then she was 38 something weeks.
So cool.
Yeah. Again, if you have a confident practitioner who's confident in breech, and you have to be if you're going to take care of twins, then breech is just a birth that a baby comes out butt first. It really is. If you know the maneuvers, this is what I teach as I go around the country and teach this course.
You're reteaching.
And the kind of feedback I get is great from people. And I love hearing from people who had a breech birth afterwards and said, it's just like the videos you showed us. I didn't have to do anything. Or the baby stayed in sacral transverse position. I knew right away that one of the arms was behind the head and I knew exactly what to do. And I did my maneuvers. The baby came out just fine. Again, it would be so easy to teach residents. I could teach OB residents. Give me a day with an OB resident.
That's all it is.
Right.
Yeah. It's one day. The Breech Without Borders was just here in St. Louis, like yesterday and the day before. And so that was my second Breech Without Borders training. And it's one day.
Yep. Right. Doesn't make you an expert.
Why isn't everybody taught this?
I don't know. It's fear and economics, but the idea that you may not be a breech expert after taking the Breech Without Borders or my class,
right?
But you'll know what to do. And everyone who practices obstetrics I hate that word. Everyone who deals with pregnant women, if they deal with them long enough, is going to have a surprise breech.
Of course.
And they're not going to. And I hear these stories where a woman shows up completely dilated, with the feet in the hanging out of the labia, and they take her back and do an emergency C-section on her. Okay.
And then they label it footling breech.
You could have that baby out in
accurate.
literally 15 seconds. You could have that baby out vaginally.
Yeah.
Right.
Yep. It's crazy. And okay. Yeah. I know you're probably on the end of your time. Yep. So we really appreciate you being here. Is there any like last minute little nugget or words of wisdom that you want to share or thoughts?
No, I think the whole thing has been words of wisdom.
Yes.
And some hyperbole and a little bit of snarkiness and some mocking that goes on. But you know,
okay.
that's how my personality has developed over the years. And there's nothing I can really do about that. I'm not going to change now. I just think that you should trust your body, and you should
Absolutely.
trust and find a practitioner who is also trusting of your body.
Right.
Because again, midwives and people like me, we're so good at normal birthing that we recognize when things aren't normal, and we can either intervene when necessary or transport when necessary or transfer care when necessary.
Yeah.
But to the idea that every twin pregnancy is high risk is a mistake. It's not true.
Yep.
It's labeled high risk because that's the nomenclature we use. But it's not high risk.
Right.
If you know what you're doing and you properly select your clients and you have the skills to deal with it, then it's not high risk. It's higher risk, but higher risk doesn't mean anything if you don't know what the denominator is. If you don't know, like we talked about earlier, 99.93% versus 99.886%.
Right.
Chance of it not happening. What's the difference?
Right. So true.
Yeah.
Awesome.
Okay.
Thank you so much for being here, Dr.
Thank you so much.
This has been so fun for Tiffany and I.
Yeah.
You're welcome, guys. It's been my pleasure. I have to go.
Yes.
Just send me the information. People can find me at birthinginstincts.com.
Perfect.
And the Birthing Instincts podcast and Birthing Instincts on Instagram. It's not very complicated. It's all Birthing Instincts. Right.
I'll put it all in the description below.
Okay.
All right. Thanks for listening, guys. Bye. Hi, Rachel Manns again. If you want to learn more, please subscribe to and rate this podcast, and head over to thenaturalbirthsite.com to check out our online natural birth education course, birth story blog, YouTube channel, and more.